And spoiler alert, I don't get it all out in one. I do remove it in tiny little pieces. And I use at quite a high RPM, which is 1,000. And I'm just going to drill the GP out. These tiny fragments are really, really annoying because you can spend half an hour cleaning out all of the tubes in a tooth, and then spend about an hour and a half on tiny little fragments. Hello. Welcome to this week's clinical case, and this is a case of I do a lot of consultations for re-root treatments, and when we look at these types of cases, these are the types of re-root treats that you want to be doing, okay? Because we've just had one this morning where it's been done by a colleague of mine, and he's done an absolutely fantastic job of this tooth. The root canal is stuff for dreams, but the patient's still having symptoms, which is really, really annoying, isn't it? And I suppose with patients, what you want is you want to look at the root canal and think, well, that's not been done fantastically for whatever reason. Okay, it doesn't really matter if it's been done well or not, or why it's been done well or not. It's the fact that, if you look at a root canal and you think to yourself, well, this can be improved, well, that's better for the patient. So in this case, when we look at this tooth, this lower left 6, we can see that this obturation isn't the best. And I know for a fact that I'll be able to get all of this obturation out. I'll be able to make this root canal look much, much better than it does now. And I think it personally, it's got a really good shot at working. But I want to say, before we get into the case itself, when we look at the metrics of the channel, only 50% of the people who watch these videos are subscribers. So if you could just do one thing for me, it's simple, it's quick, it's easy, and it's free. Just hit that subscribe button. If you hit the subscribe button, it pushes the channel along. It makes me feel like I want to do these videos even more. If you want to bring that support even further, we've got the membership program run by YouTube. It's a small monthly fee. You get early access to videos. So we usually work in about 3 or 4 weeks ahead with these videos. If you like these videos, you can see the ones that are due to be scheduled to drop in subsequent Fridays. And also we've got early access to content. We've got access to early, and of course we've got access to exclusive content. We've got a fantastic endodontic access video, and we've also got our sort of survival guide for newly qualified dentists. So as mentioned before, we look at this periapical radiograph and we can see it's a lower left 6. It's got some kind of inlay, onlay. I think it's an inlay, to be honest. And it's got a poorly obturated, or less than ideal obturated tooth with quite a large apical infection. And of course, when we look at this periapical radiograph, my straight away concern here is possibly a fracture. Now, there's no obvious true sign that there is a fracture, but obviously this is a root-filled tooth. It's got a very, very large restoration in it, and also it's got this kind of, I don't know, maybe if you squint your eyes, it's a bit of a J-shaped lesion, but the lesion runs from the apical all the way up to the furcal. So that is my main concern, and obviously with the consultation process, the patient's going to be made aware of this, and she can be made aware that if we access the tooth and we see a crack, then we might need to investigate that, and it might need to be remove the tooth. So we'll move over to the video here. We're obviously going to place rubber dam and I'm going to make an access here, but I'm not going to remove the whole restoration. And people would argue, maybe you shouldn't remove the whole restoration, but I feel like it's a pretty solid sort of inlay onlay. And in fact, when we sort of drill into this and we have a little look, we can see that the restoration is pretty solid. And I think in this case, I'm going to leave it in place. And when we have a little drill, we can see there's a bit of a glimmer of GP. So I'm going to have a little bit more of an investigation, a little bit more of a refinement of the access cavity. And now we can see the vast majority of the access cavity here. And then I'm going to use a DG16 endodontic probe, just to have a little fiddle around, just to make an assessment of what the GP is like, because like this morning we did a re-root treatment, and the GP was all nasty, and it was I just knew it'd come out straight away. But when we look at this GP, it feels like, despite the periapical radiograph, the pre-op radiograph, we can see that it's pretty wedded, pretty solid to the canal wall. So this is a slight red flag, knowing that we're going to probably spend a bit more time than usual trying to pull all this GP out. So I'm going to just clean it out with an ultrasonic, because I just feel like there's a lot of nastiness in there, and it's looking a little bit cleaner. But again, using the ultrasonic, sometimes it can be beneficial, because you can just give it a bit clean up, so you can see a bit more visualization. But also what it can do, it can break up the GP, and what we want to do is we want to remove this GP in one, if possible. Removing it in little tiny fragments, what this can do is that it can just make your job a hell of a lot harder. And spoiler alert, I don't get it all out in one. I do remove it in tiny little pieces. So, and in the end, it is what it is, isn't it? So in the first instance, I'm going to just try and remove this with a Hedström file. But before I do, I like to put some sodium hypochlorite. You'll notice I'm using a steel syringe here, because when we're doing our irrigation, especially when we do a re-root treatment, the plastic Irriflex tips that we use can sometimes be bent, and you've got to replace them all the time. So you'll notice at some point I replace the tip, but I just like to use the silver just for now, because it's a bit more robust. And then, like I say, I'm just going to use a size 25 Hedström file here, just have a little screw in. I'm going to go straight for the distal, because it's the biggest and usually the easiest to do. I have a little feel around, but it's not really working. So I like to use these ToothSaver files. They're a size 2007 taper, and I use at quite a high RPM, which is 1000, and I'm just going to drill the GP out. Again, I do like to remove it in one, but sometimes it just can't be removed. So this is a really efficient file to remove GP with. And then as we irrigate here with our silver irrigation, we can see that a lot of this GP is getting removed. And again, once we've irrigated, I'm going to go back in with the size 2007. And then I also like to irrigate and activate the irrigant, and this sometimes dislodges pieces of GP. Another thing I didn't tell you is that this has got a double distal canal, so this is why it's taking a little bit longer than usual. And then we're just have a little feel around with the DG endodontic probe under high magnification, and I can see that it maybe looks like it is a full piece of GP, like a GP cone, but it's quite frayed because it's been sort of drilled with the rotary file. And I think because it's so frayed, it's kind of getting caught on the canal wall. So what I'm going to do is I'm going to leave that to one side. I'm going to lay that to soak in sodium hypochlorite, and I'm just having another little feel around with a DG16 endodontic probe just in the medial aspect of these canals here. And then leaving the distal to soak, and I'm having a feel around now with a size 25 Hedström in the mesial canals. Again, that's not working very well, so we're going to go straight in with the size 2007 ToothSaver file, again at a really high RPM, and you can see here now it's really drilled all that GP really nicely. And then once I give this a little bit of an irrigant out, I notice that there's quite a significant amount of sealer on the walls here, and this is obviously going to affect the way that this tooth is cleaned. So I'm trying to have a sort of pick off with the DG endodontic probe. Doesn't work very well. So what I do use is I like to use my activation, my ultrasonic activator, just to remove some of this sealer. Two things you want to be careful of. One is you don't get very large pieces of sealer drop down into the canal space. And also, and the reason why I'm using this activator is you don't want to use something too strong, because you don't want to cause a perforation within this canal space. And then just being really gentle. I think with these low energy ultrasonics, you're not likely to cause very large fragments. It's going to be like a bit of a powder. And then once I have cleaned it out as much as I can, I'm using these fantastic XP-Endo Shaper files. So it's kind of like a wavy file, and this is scraping both these canals here, both these mesial canals, getting rid of all the nastiness. And again, if you haven't got these, get to use them, especially with your retreatment cases. And I feel like I'm negotiating pretty well to length. So straight away, what I want to do is I want to check the working length, because what I don't want to do is I don't want to be shaping these canals past the zero reading. We get a zero reading straight away, 18.5 millimeters, I believe, on the MB, and then I'm going to just check the ML. Again, this goes to length really, really easily, and it transpires these two canals join, but that's for a later part of the video. And then again, I know I'm to length, I know I'm dropping down really nicely. I want to just get my final shaping in really, really quickly, because I can then say that them two canals are put to bed, we can irrigate those, and we can concentrate on that final little bit of a fragment of GP in the distal. So both the mesials are shaped. I'm just going to use a bit more ultrasonic activation in these canals, just to make sure I activate the irrigant. And again, we can see there's a small piece of GP remaining, and we use our DG endodontic probe here just to have a little feel around. And again, if you do a lot of reroot treatments, these tiny fragments are really, really annoying, because you can spend half an hour cleaning out all of the tubes in a tooth, and then spend about an hour and a half on tiny little fragments. But it's really, really important that you remove these fragments for sure. And a lot of times these fragments are removed by ultrasonic activation, dry. They kind of, if you use the ultrasonic activator and put it on the GP, sometimes it floats up the tip. In this case, it doesn't work, so I'm just going to use the XP-Endo here just to give it a bit of a clean out. And again, this is done at quite a high RPM, and hopefully this catches the GP. And we notice here, as we use the irrigant in the GP, that final piece of GP is removed. So again, we're just going to do a bit more activation with our ultrasonics, give it a good old clean out, and you'll notice here that the activation, this irrigant goes from clear to sort of pond water, and then we have another little feel. And then look, I thought the last piece was the last piece, but this is genuinely is the last piece of GP. And again, now it's completely clear. We can see that it's nice and clear. And we just need to make sure now that we're not going to finish this root canal now. We are going to make sure that it's all nicely irrigated, and get the working length on this distal. That's been done off shot, and we give it just a lot of irrigant, shaping, irrigant, activation, shaping, irrigant, activation. And again, I'm going to do a final round of the XP-Endo Shaper. And I thought the second to last piece was the last piece. I thought the last piece was the last piece, but actually when we use this Endo Shaper and we give it a good old clean out and a bit of an irrigant, again we finally see that there's a tiny the final piece which has been removed. So what's important is that I thought the second to last, or the third to last piece was the last piece, and I thought the second to last piece was the last piece, and now I confirm that this is genuinely the last piece. And how do I know that this is the last piece of GP? Well, of course, you can just keep shaping the files with all manner of different filing systems. This is a XP-Endo finisher. I do like to use this, but I do prefer the finish. This is the XP-Endo finisher. I do prefer the XP-Endo Shaper. I feel like it's a bit more robust than this, but I was concerned about just remaining fragments. But to confirm that you've removed all of the GP, the best thing to do is take a periapical radiograph, and we can see here now that both canals are completely clean. So all we need to do now is we just need to finish again our irrigation protocol, activation, sodium hypochlorite, and then we're ready to close this tooth up. And in my case, what I like to do is, I know that a little bit of sodium hypochlorite and a little bit of non-setting calcium hydroxide actually works really, really well, and it creates this kind of liquidy solution. So I'm going to obviously do my final irrigation protocol, leave a little bit of liquid in, and I'm going to backfill all 3 canals with this non-septum calcium hydroxide. And sometimes, calcium hydroxide comes in all different types of pastes and liquids. And sometimes when you get a really, really sort of pasty kind of non-septum calcium hydroxide, it doesn't get down the canal very, very well. So this is why I leave a little bit of sodium hypochlorite just to mix in. And then obviously I'm just going to use a file to introduce the Medicament into all of the canals. And I like to put a bit on the end as well, and make sure you've got the canal space all nicely filled up. And then to close it up using PTFE. Again, I like to use PTFE over cotton wool, because when I'm going to remove this at a later date, the cotton wool just gets stuck in all the GIC. So we're going to push that down, use a couple of little Mach 2 pluggers just to sort of push the PTFE into the access cavity. And then we're just going to use a bit of GI, a bit of cheap GI. And then, it's all nice. You just tell the patient, just be careful. And this now at later date can be really easily removed. Patient comes back for the second appointment, and again we're going to obviously rubber dam. We look at the temporary, it was just pushed on there, and it's lasted really, really well. We're going to drill the temporary out, and you'll notice when you're using a fast hand piece and you use it onto the PTFE, it doesn't get caught like it would with cotton wool. We give it all a bit of a clean out, and then straight away, I know that I've shaped all of the canals, but the most important thing for us to do now is just to check all of the working length. That's really, really important, because obviously it just reorientates yourself with the tooth itself, and also it just checks that when you come to obturate the tooth, you're not going out the end of the tooth. And the amount of times I've rechecked the working length and it's been different to my original working length is quite a lot of times. Luckily in this case the working lengths are exactly the same, and we are now ready to do our conefit radiograph. And what I do is that I remember my master apical file was a 25, but when I push the matched cone to length, it pushes all the way through. So I'm going to use a size 40. This pushes to length quite nicely, and luckily in this case I don't need to apically gauge this tooth, because the size 40 reaches to the correct working length, and I don't need to cut the end of the GP off to, it's essentially the end of the GP cone is at a size 40. And again, I use the size 40s in all the other canals. And also, do you remember I was talking about the distal's got a double distal? You can see here that I have to place a extra accessory GP cone in the other distal canal, and when we take the conefit radiograph, we can see everything's all really nice to length, and it's looking better even now compared to the pre-op. And now we've just got ready to obturate the tooth. Super simple, nice and easy. And as you know, you can see here that I'm just snipping off the GP cones, because I like to sometimes I feel like it gets caught in the rubber dam, but also when I push it to length, I know where it's being cut. It fits really nicely. So we've done the conefit radiograph. I'm going to remove all the GP cones, and they are going to be disinfected. And then I'm going to do my final irrigation protocol: sodium hypochlorite activated, EDTA activated, and then sodium hypochlorite activated. I've now moved over to 5%. Some people might say, oh, you should have been using 5% all the time, but it's just cause a habit. I've been using 2% for so long. We do the drying of the canals. We want to make sure that we are drying the canals nicely, because what we don't want is the bioceramic to wash away. And in these cases, I'm using these high flex size 40 drying paper points. And then to do the obturation, I'm going to use one fill. It's a bioceramic with these visco tips, and I'm just going to make sure I'm filling the distal canal really, really far up. And you can see that the distal one of the distal canals is really, really filled up, and then the other distal canal is starting to fill up at the same time. This indicates that these two are joined, and I'm going to just introduce the GP cone really, really nicely and slowly. And then obviously once this has been introduced to the full length, you can see that the other canal is now filling up, because because obviously this is the point where the bioceramic is venting. Although I want to make sure that the other canal is really full with bioceramic, so I'm just going to backfill that ever so slightly and then push this accessory cone to length. And once it's been pushed to length, we're going to get our heated plugger and we're going to just kind of cut off the excess. And it's just, you know, it's just a really nice chilled sort of process this. You want to make sure you're doing it all really nicely and sort of with purpose. And you know, sometimes when I've got a really wide canal and I don't put enough accessory cones in, when you come to condense it down, of course the GP isn't filling the vast majority of the canal space, but the sealer is. And when you're pushing down, sometimes the back tube plugger can like kind of slip off and push down into the sealer. So that's another reason why I like to fill the canal space with these accessory GP cones, mainly because I can condense it down really nicely. And again, you know, we just same sort of process and protocol with the other canals, and we give it a bit of a clean out with our ultrasonic, and we can see now that everything's looking really nice. And when we look at the post-op radiograph, again, everything's to length, everything looks great. I'm super happy, and of course, you know, there is that risk, isn't there, that there's a lot of tooth tissue missing here, and the patient, of course, has been consulted and then consented for this. But I think if we get some cuspal coverage on this tooth, I think it'll last a decent amount of time. And overall, thanks for watching. Another little simple case here. Again, if you like the channel, please like and subscribe. Join the membership program if you want to see early access and exclusive content, and I will see you in the next video next week. Bye bye.